around 25 years, and we've all gotten comfortable with rituximab. However, there are a few things that um, we still don't know about this drug, and I will just tell you the practical aspects of usage of rituximab. So, when we go to the history of B cell depletion, uh, actually the whole monoclonal antibodies were started after the hybridoma technology came in. And this was introduced in 1975. This was a Nobel Prize winning uh, uh, dis- uh, technology by Kohler and Milstein. And subsequently, a whole lot of monoclonal antibodies were produced initially with the intent as of use of diagnostic tests. And that is how immunology expanded after the production of these monoclonal antibody, which could be used for the identification of surface proteins in immunology. And the field expanded a lot. And in 1985, a first monoclonal antibody was developed against CD20. So in in 1994, the IDEC Pharmaceuticals first developed a chimeric antibody against CD20, which was subsequently approved in 1997 for treatment of NHL. So actually, this anti-CD20 monoclonal antibody was actually not developed for use in immunology or in for any other immunomodulatory indication. They were actually initially used for the treatment of malignancies or hematological malignancies. The usage of rituximab in both for autoimmune diseases actually was rather serendipitous. In 2001, Edwards et al. Published an open study of 5 patients with RA. How this was stumbled upon is because rheumatoid arthritis increases the risk of non-Hodgkin's lymphoma, and when they used it in RA patients with non-Hodgkin's lymphoma, they realized along with non-Hodgkin's lymphoma, their rheumatoid arthritis also improved. A similar observation was made in AIHA associated with CLL, and subsequent studies showed that rituximab was efficacious in rheumatoid arthritis. And subsequently, this was the first indication for which rituximab was approved by the FDA in 2006. And subsequently, studies showed its efficacy in ANCA vasculitis following Grave and rituximab. And it was in 2014, there was a seminal paper that looked at it as an effective regimen, even both for induction and subsequently for maintenance in ANCA vasculitis. So this is a brief history of rituximab. And so the first question is, why should we target B cells? It seems very, very simple when you actually say, okay, autoantibodies, B cells. However, actually, we have to look beyond B cells as just antibody producing cells. Their functions and their role in immunity is beyond just production of auto antibodies, and in disease, production of autoantibodies. So I will come to why that question is so important in rituximab. So what do B cells do? So they provide help for T cells. So they provide a co-stimulatory help to T cell molecules. They actually also take up antigen, process it, and are very effective antigen presenting cells. They produce numerous cytokines that support other mononuclear cells. There is also antigen induced production of IgG and antibodies, and they also form memory cells which await antigen re-exposure. So these are its physiological functions which are undergo a dysregulation in disease, and thereby they form a very appropriate and very good target in numerous autoimmune diseases. So there are numerous B cell targeted therapies, which the most common ones, of course, be the one which targets cell surface molecules, which are anti-CD20, that's rituximab, ofatumumab, and there are others which are BAF, BLIS blockade. These come further in the pathway of B cells, and there are downstream inhibitors. So first question is, what is CD20? So actually CD20, the exact role of the CD20, what it does in physiology is really not known. It's a cell surface molecule on B cells. For ages, it is used as a B cell marker. Even now, even with the presence of rituximab and other B cell molecules, anti-B cell therapies, we really don't know what and CD20 does in physiology. There is a known natural ligand. It is just a specific B cell marker. It is thought to be a calcium channel subunit. And this was the observation that was made that led to the usage of rituximab, that rituximab did not require an to be anti-CD20 led to B cell depletion without the need for a conjugation to a toxin. So the moment rituximab it just binds to anti-CD20 and B cells underwent apoptosis for some reason, there was no toxin conjugated to that. So exactly why this happens is not known. There are various theories that are proposed. So if you look at where CD20 is expressed, this is B cell development. So we see that CD19 and CD20, they're very specific B cell markers, and somewhere in the pre-B cell stage, CD20 is expressed up till the memory B cells. So what is important to understand here, plasma cells, which is where primarily antibodies are produced, are not affected by CD20 because they do not express CD20. And memory B cells also express CD20, but not all memory B cells. So if you give an anti-CD20 therapy, you are not acting on the plasma cells. And this is very important from an adverse effect point of view, because if the plasma cells are not affected, you will still have antibodies which are being made. So this is where these are the cells there which will be affected by your CD20 molecules. So what is rituximab? It is a chimeric molecule, which means it contains this variable portion from the heavy chain and light chains or from the mouse antibody, and the rest of the portion is from a human IgG antibody, and thereby this chimeric molecule is formed. So all the ZMABs are chimeric molecules, like infliximab, it is a chimeric molecule. MUMAB are humanized, and the ZUMABs are humanized and MUMABs are human. So that is how the terminology goes. So chimeric will obviously have a higher risk of hypersensitivity reaction and also formation of human anti-chimeric antibodies, because obviously they contain non-human portions. So that is the importance of knowing that this is a chimeric antibody. So how does B cell depletion occur once rituximab binds to a B cell? So this is a representative diagram of a B cell, and these are the CD20 molecules. And then this is the rituximab which comes and binds to the CD20 molecule. Now, once this is bound, there is an antibody mediated cytotoxicity which occurs, which is complement mediated. These complement components will come and attach to the FC portion, the complement receptors, and then this cell will undergo lysis. NK cells can bind. They will have FC gamma, that is, this is the FC portion of the immunoglobulin, and these are FC receptors which are present on the NK cells. These will also bind to this antigen antibody complex, and under the cell will go direct lysis. And this is antibody dependent cellular cytotoxicity, which is dependent on a macrophage, and this will also go through the FC gamma receptors, which will bind to the B cell. So all these pathways will contribute to your B cell depletion. So B cell depletion will occur by cell complement mediated cytotoxicity to your ADCC or antibody dependent cellular cytotoxicity, or direct lysis NK cells. The net effect will be to cause a profound B cell depletion. So this is a summary. So antibody dependent cell mediated cytotoxicity, which is through the macrophages, which will bind, which will contain the FC receptors, which will bind to the FC portion of rituximab and cause cell lysis. Complement mediated cellular cytotoxicity, again through formation of membrane attack complexes, and also through direct lysis to the NK cells. So the net effect will be reduction in pathogenic autoantibody synthesis, because once you act on the B cell, obviously the B cells reducing the maturing into plasma cells is reduced, and thereby we think that this is one of the mechanism with which pathogenic autoantibody synthesis is reduced. Cytokine release will be reduced. B cells will Also, the B cell antigen presentation, which is one of the primary mechanisms in autoimmunity, will also be reduced, and thereby contributing to all its therapeutic effects. So what happens to B cells after rituximab? So there's a profound depletion of CD9 positive B cells. Why we do CD19 and not CD20 to look for B cell depletion after giving rituximab is because rituximab will directly attach to CD20, so that we cannot really detect on a flow cytometry after that. It will interfere with the test. That is why to look for B cell depletion, we have to do CD19 positive B cells, which usually show a very profound depletion after rituximab. So once the B cell phenotype also changes after rituximab, with most of the B cells being either plasma cells or memory B cells. Like I told you, plasma cells do not have CD20, so they will be spared. And certain memory B cells also do not have CD20, so they will also be spared from the effects of rituximab. So most of the B cells after B cell depletion therapy will be memory B cells of plasma cell precursor phenotype. And once they replete also, they seem to have a different phenotype, with immature naive B cells or transitional B cells as we call them will be more compared to mature B cells. And memory B cells remain below baseline for longer. It does not have any effect on T cells or NK cells. This is one of the relative safety features of rituximab, is that it does not have effect on T cells, NK cells, plasma cells. So unlike broad immunosuppressants, for example, when you look at steroids or cyclophosphamide, why rituximab is thought to be a relatively safer molecule is because it is very specific in its effect. It only attacks the B cells. So you don't have any effect on T cells, you don't have any effect on NK cells. And additionally, you do have some plasma cells which can produce antibodies. So certain B cells, rituximab is less efficacious against, that is B1 cells, marginal zone cells, and B cells in gut-associated lymphoid tissues. These are slightly different cells and belong to a more primitive form of immunity that we have. So these cells are spared, again contributing to both sometimes its resistance as well as its marginal safety. What about the effect on antibodies? So usually IgM levels are the most commonly affected, usually in about 25% of the patients. However, they are not affected to a very great degree. Most of the hypogammaglobulinemia is transient. In less than 1%, you get persistent hypogammaglobulinemia. And in this subset, we think it is actually a form fruste of common variable immunodeficiency that these patients have, that has been missed in the pre-workup. And if you look at RA patients, the rheumatoid factor reduction was greater than in serum immunoglobulin, and this correlated with response. However, there was no correlation as such found in lupus, Sjogren's, and ANCA-associated vasculitis with autoantibody levels. So some of the mechanisms of resistance that have been described, and this is inherent to its mechanism of action, is the Fc gamma receptors itself have low affinity, and there's decreased complement in lupus. So the complement mediated cytotoxicity is not taking place, so B cell depletion doesn't occur. And increased BAFF levels, these are primarily described for lupus, but may be relevant to all other autoimmune diseases. So coming to the FDA approved indications, you will be surprised that there are very few actually class A FDA approved indications. Even in rheumatology, the only two FDA approved indications are rheumatoid arthritis and ANCA vasculitis, that is granulomatosis with polyangiitis and microscopic polyangiitis. So actually speaking, there are very few FDA approved indications. However, rituximab has very wide usage in various other diseases, and the off-label indications that are for which there is reasonable amount of evidence is inflammatory myositis, lupus for the hematological manifestations, and also for TTP and primary Sjogren's. In systemic sclerosis, ILD, there is recent evidence to show that it is efficacious. It's also used in primary APS and cryoglobulitic vasculitis. So these are all the other indications for which rituximab has been used, and in some there is good evidence to show its efficacy. So if you can see, the green ones signify that the primary outcome was achieved, and you can see this is an ANCA vasculitis, autoimmune hemolytic anemia, and There is among this blistering skin diseases, there's reasonable amount of evidence which is coming in myasthenia, in systemic sclerosis. So these are some of the diseases in which we do use IgG4 related diseases. These are all the diseases that we are using rituximab quite widely, and although these are so-called not FDA approved indications. So what are the dosing regimens that we have? So it is very interesting to know that actually the dosing of rituximab is actually not based on robust pharmacokinetic or robust pharmacodynamic data. In fact, it is a very, very empiric regimen. The initial reason why this 375 milligram per meter square into 4, that is weekly regimen of 375 milligram per meter square was brought in place was simply because this was the regimen that was used for CHOP, and the first indication for rituximab was NHL. So it seemed it was a convenience dosing that was used, that okay, we are going to use it like this because weekly we are giving CHOP, we will give R-CHOP instead. So that seems to be the only rationale. I've actually looked at this more carefully, and there is actually no real reason why we should not be giving a single injection, or we should be giving 2, or we should be giving 3 or 4. So, or the rationale for why it should be separated by 1 week or 2 weeks. So in rheumatology, we use both regimen. 375 milligram per meter square is actually the FDA approved dosing regimen for ANCA vasculitis, whereas 1 gram, 1000 milligram into 2 is the dosing regimen, which is approved for RA. And a low dose regimen, 500 milligram into 2, both of these are 2 weekly apart, has also been again proven efficacious in RA. So for convenience, most rheumatologists do use 1000 milligram into 2, and there is data in even vasculitis as well as in lupus and other diseases to go with the 1000 milligram into 2 regimen, and this works out better for the patient because it saves him 2 hospital visits. Also tends to be slightly on the dosing tends to be slightly lower for patients, of course, with higher body surface area, because 375 milligram per meter square is a BSA based regimen. So in patients with, obviously it tends to amount, even in Indians it will be about 2.5 gram, 2.75 gram, whereas this tends to be just 2 gram. So what about its efficacy? So in rheumatology, one of the primary indications is rheumatoid arthritis, and its efficacy has been shown for both dosing, that is 1000 milligram into 2 doses or 500 milligram into 2 doses. The only difference between these 2 dosing regimen was that the radiological progression of rheumatoid arthritis at 1 and 2 years seemed to be lower in patients who were given a higher dose regimen. However, for all other outcomes, it seemed to be equivalent. And so a lot of us, and there is a lot of retrospective data also with the, which lends itself to its efficacy. So both dosing regimens, and so now based on patients' pocket, 500 milligram into 2 is one of the most popular regimens that is used for RA. And when it comes to ANCA vasculitis, these were the seminal papers which 2011 RAVE and rituximab trials, in which it was shown to be non-inferior to cyclophosphamide. And subsequently there was a paper in 2014, which is main Ritsan and Ritsazaram, which showed that rituximab was superior to azathioprine in the maintenance of remission. So current standard of care for maintenance would be rituximab and ANCA vasculitis. And for certain diseases, like in relapsing diseases, rituximab is superior. Contrary to what one would believe, that because it's such an autoantibody mediated disease and B cells are so central to lupus, one would believe that it should be a very efficacious drug in lupus. Counterintuitively, however, it works only in AIHA and ITP. That is similar to other AIHA and ITP, even non-lupus AIHA ITP, where rituximab works. And in most other manifestations of lupus, rituximab has not shown the kind of efficacy that one would expect. And most of the trials, at least some very important trials, this looked at renal lupus, and it failed to demonstrate the superiority of rituximab when added to MMF compared to MMF plus corticosteroid alone. So again, this was a negative trial, and rituximab was not superior. So you can see in this, looked at the renal responses were similar between patients who had received only MMF or MMF plus rituximab. So there was really no some difference in the partial response, but this was also overall, when they looked at the response, it was not statistically significant. So so that is why rituximab is not currently the standard of is not used for lupus. Very rarely we may use it in some patients with where we have no other options, but there is nothing to say that it is currently, we don't have much data to say that it is effective in renal lupus. This was another trial which was in non-renal lupus, again which did not achieve its primary endpoint, and there was no difference in the clinical response between patients who were given placebo versus rituximab. Again, this in one of the problems in both these trials was the patients, the control arm continued, and the treatment arm continued to receive standard of care, and rituximab was used as an add-on treatment. And because we cannot deny treatment in patients of lupus, and the structure of the trial was like that. So both of these important trials failed to show any superiority of rituximab. So it has got very few indications in lupus, contrary to what one would expect. The other situations in which we do use in rheumatology are myositis, for which there is some evidence in refractory myositis, and most of these are retrospective data. So what are the screening that we need to do before rituximab? A detailed history needs to be taken. Any comorbidities, any recurrent infections. This is very important because there are some patients, if we do have recurrent infections, it may be a risk factor for future infections with rituximab. And viral markers obviously have to be done. Chest X-ray. Baseline immunoglobulin levels are recommended, because if they are less than 0.5 gram per deciliter, then it would be better not to give rituximab, because the risk of infection would be much higher in this subset. If there is an indication for which absolutely you need to give and you don't have another choice, then it is recommended that this be done along with immunoglobulin replacement treatment. And in case a patient has already received something like a TNF inhibitor, then it is recommended that rituximab should be given only 4 weeks after last dose of etanercept and 8 weeks after infliximab or adalimumab. So one of the most important risk factors is hepatitis B, and both hepatitis B and C should be screened for. And screening for hepatitis B should include hepatitis B core and antibody, that is HBC AG total. This is because even patients who have HBC positivity can undergo a reactivation when given rituximab. Rituximab, in case, I will just come to the next slide. So it is recommended by the ASLD guidelines to screen for this before rituximab is given. It is actually not so important we don't screen for core antibody with other cytokine inhibitors like anti-TNF or secukinumab, but for rituximab, it is absolutely required, because reactivations are well known with rituximab. So there is this risk stratification. This is as per the ASLD guidelines. So for anti-CD20, when there is HBsAg positivity, it is very high. So this is very high, indicates greater than 20% risk of reactivation. So what is recommended is that in this situation, it is preferable to not give rituximab and to decide on some other therapy, because the risk of reactivation is so high. Whereas anti-HBsAg is positive, then you could still give, although there's a moderate risk of reactivation, and this should be along with entecavir, that is antiviral treatment. So this is very important. That is, even if HBsAg is negative, anti-HBsAg should be done, and treatment. You could actually change your course of treatment depending. Like, for example, if I had a patient of ANCA vasculitis who is HBsAg positive, then since I have the option for induction to give cyclophosphamide, my choice may be to give cyclophosphamide in this situation rather than give rituximab because of the associated HBV reactivation. So this algorithm helps you to make your choice. In any situation, if you have to give rituximab for whatever indication, then this should be in consultation with the hepatologist and along with the antiviral therapy. Usually that would be entecavir. So with hepatitis C, it's a little unclear as compared to Hep B. There are reports of safe usage of rituximab. It has been in fact used in hepatitis C associated cryoglobulinemic vasculitis, and thereby it may be safe. So even though flares have been reported, they are usually well tolerated, and currently there is no recommendation on any prophylactic antiviral in HCV positive individuals prior to rituximab. TB screening. So rituximab, the risk of TB in patients given rituximab is similar to baseline. So most of there are large registry data for this, in which in patients who were given rituximab, it was not associated with the active TB, or the risk of TB or incidence of TB was similar to that of the incidence in the country. And so it is not, we don't need to really do a MANTU or a quantiferon before giving rituximab. Most of us don't do this test because actually it is not associated. The risk factors usually tend to come from the fact that in most diseases where we use rituximab, we would concomitantly be giving glucocorticoids, which in itself may contribute to the increased reactivation of TB. So what about serum immunoglobulins? The low baseline immunoglobulin before rituximab increases the risk of serum serious infection. So this is considered to be 0.5 gram per deciliter. So in case it's less than that, one could make a choice to not give rituximab. If you look at data, this has come from RA patients, about 25% will go into low IgM levels. This is not really associated with very serious infections, and only a small percent, only 5% of RA patients will show low baseline IgG levels. If there is a sustained low IgG, this may be a risk factor for respiratory tract infection. So the other risk factors include increasing age and concomitant glucocorticoids in patients with and this requires stricter vigilance. So what about vaccination? So because it's a B cell molecule and obviously it would interfere with the immunogenicity of a vaccine, you should give a non-live vaccine according at least 4 weeks prior to the first dose of rituximab. So after giving rituximab, live virus is not recommended. Do not give a live virus. As far as non-live virus, there is no safety issue with giving a non-live virus, but they are unlikely to be immunogenic. So kill vaccines like Pneumovac or Prevenar, if you want to give, ideally they should be, if they have to be immunogenic, they have to be given 4 to 6 weeks prior. But in case, especially like in vasculitis or any other urgent indication, you cannot do that. So it's recommended that you give it 6 months later and before the next dose whenever you're planning. So it's very difficult to do that. Usually I do give, even though the immunogenicity may be low, I tend to give pneumococcal vaccines because kill vaccine, like I said, the issue is of immunogenicity and not of safety. So in case you do give, Prevenar may be one of the better options to give because it's a conjugate vaccine and inherently more immunogenic than the non-conjugate, that's Pneumovac 23. However, again, there is no data to back that. And if you're giving, if you can plan it, like in rheumatoid arthritis, we can plan rituximab. So we tend to give it at least 2 weeks to 4 weeks before the dose of rituximab. What are the other important safety issues? So infusion reactions are an important safety issue, and it's in very rare cases, even death has been reported due to an infusion reaction. So in case a patient is having a severe infusion reaction, this is an absolute contraindication. Do not retry rituximab. And one of the ways to prevent an infusion reaction is to give pre-medication with methylprednisolone and antihistamines. And usually we start very, very slow, usually 50 ml per hour. And that is the speed at which we start whenever we are giving the first dose. And that's one of the way of watching for a reaction. Immunogenicity compared to the other molecules, it is more rituximab, although it has to be, when you think about it, because it's a B cell molecule, we do not get as much anti-chimeric antibodies like we get with infliximab, because it directly acts on the B cell and antibody production. So the immunogenicity is much lower as compared to another chimeric molecule. However, anti-HACA antibodies have been reported. Hypogammaglobulinemia, low serum IgM is in 22.4%, which tends to be transient and tends to recover in 6 months to 1 year. IgG in very small percentage, 3%, and IgA. And serious infections occur in less than 1% of patients in with rituximab. And herpes zoster is again rare and is similar to those treated with methotrexate alone, and it may not be an independent risk factor. It is mostly got to do with the background immunosuppression. Tuberculosis also is background, and hepatitis B I've already discussed. Other rare infections include progressive multifocal leukoencephalopathy and pneumocystis jirovecii infections, which have been rarely reported. So the most of the infections that have been reported are actually upper respiratory infections and pneumonias, and that all other infections have been reported, but like I said, it is considered, and most of this data is come from rheumatoid arthritis, wherein because there you're not using other background immunosuppression, and the dosage of steroids that we use is usually low, and it has been seen that in most of these patients the risk of infections actually come from steroids and especially from steroids and background immunosuppression and other diseases, rather than the biologics alone. So overall, the risk of infection is quite low in rituximab, so it is a rather safe drug. One of the reasons for the safety, like I said, it's a targeted molecule and does not act on the T cells, does not act on the plasma cells, and that contributes to its relative safety. So the only increased risk of adverse effects as compared was associated to infusion reactions and development of human anti-chimeric antibodies, and 30 to 35% infusion reactions. Severe infusion leading to drug discontinuation is only less than 1%. In mild infusion reactions, with monitoring, it can be continued, and with use of steroid. The overall risk of serious infections is quite low and remains stable over 5 infusions. So this is one of the rare complications, pneumocystis jirovecii pneumonia. Again, since pneumocystis actually occurs in patients with who have cell-mediated immunity impairment rather than a humoral impairment. Again, it's not known whether really rituximab is responsible for this. However, there have been case reports in rheumatoid arthritis, ANCA vasculitis, and SLE. However, most of these patients have had additional risk factors. In fact, we have had 3 patients of myositis who have given rituximab, and within 15 days they have presented with pneumocystis jirovecii like lung disease. We have not been able to prove them microbiologically, but clinically and radiologically consistent. So it is well known, and it should be kept in mind if a patient comes back. Especially it tends to occur in patients who are on concomitant high dose medicines like steroids and other immunosuppression. So mostly been reported in oncology patients. The other very rare, but at some point there was a lot of noise about this side effect, is PMLE. So it's less than 1 per 10,000 patients of GPMP, not a very rare side effect. However, so again, whether it is truly attributable to rituximab is not known, and has been reported in lupus RA and as well as in lymphoproliferative disorder. However, in patients who are in a consistent, it can be kept in mind, especially when you when a patient comes after rituximab with a kind of a history which is suggestive of a PMLE. This should just be kept in mind that it has been reported. So the other concerns are late onset neutropenia. which may occur 1 year after rituximab exposure, and usually resolution occurs when rituximab is discontinued, and in a small subset of patients it tends to reoccur. And although if you look at every study, there will be reports of solid organ malignancy or lymphoma. However, when you look at it, they have been looked at in reviews, it doesn't seem to be that is increased risk is due to rituximab. So there is no safety signals as such right now regarding solid organ malignancy or lymphoma. So what about pregnancy and lactation? If you look at the manufacturer's recommendation, they say at least 1 year it has to be discontinued. However, when they have looked at placental transfer in significant amount doesn't occur even 12 weeks after the conception. So one could again take a clinical call in case of life-threatening diseases where there is no other alternative. Maybe 6 months is a good time where you could discontinue, and it is compatible with breastfeeding. Successful pregnancies have been reported with no B cell depletion in the neonate have been reported. However, there is not so much data that one can go by. So I think treatment should be individualized in each case, and in case an alternative drug is available, one could go with an alternative drug in this situation because of the paucity of data. So I just put this slide to just tell you, see, these are the number of anti-B cell molecules that are coming in, and in anti-CD20, also you have ofatumumab, obintumab, ocrelizumab. So there are numerous other molecules that are coming in. These are targeting the belimumab, which is targeting the BAFF pathway. And so it's actually looks like we are going into a phase of targeted molecules, and so the future looks actually very bright in terms of targeted therapies. So to basically summarize, so the indications in rheumatology tend to be RA and ANCA vasculitis, which are so-called FDA approved. However, we tend to use it in inflammatory myositis as well as in systemic sclerosis, ILD. And obviously neurology, MS, myasthenia, NMO are all demyelinating disorders are all indications currently. So contraindications, known hypersensitivity, if there is an active hepatitis B or any other active infection, cardiac failure in which you should take caution, and pregnancy. And dose, as I already said, and these are the pre-injection tests which have to be done, and vaccination should be done if feasible. And there is an infusion regimen that is mentioned in the manufacturer's recommendations. It will be inside the drug. So that regimen has to be used, and the first infusion should be preferably under monitoring, and with methylprednisolone pre-medication. So these are the take-home messages. Thank you. I'll be happy to take any questions.